Okay, a very warm welcome to all of you joining us this evening from across Europe. Our registrations show us that we have physiotherapists from 18 to 20 countries in the region, which is fantastic. This event is a direct result of recommendations from the member organizations at our last general meeting in the Europe region last year, when members asked for webinars and that we would include COVID in our work. So we put both of these together, and the professional practice working group members led by Neera Rotem-Lehrer and Hus Meerhoff organized this evening's event. Unfortunately, having caused widespread havoc, damage, chaos, suffering, and heartbreak, COVID-19 is still very much with us. And indeed, looking at the figures from the WHO today, 6 European countries are in the top list of case numbers, and in the top 10 list of case numbers, and 5 of those 6 countries are in the top 10 numbers of deaths. And we remember all of those people who have passed due to COVID. Looking at the third wave rolling across the region, it's really only this week that overall numbers in Europe are beginning to decrease, but decrease very slightly. So we are still treating people in the acute phase, and Femke Druus from the Netherlands will be presenting on the guidelines for the acute phase. And we will be going on to dealing with long COVID and sharing the experiences and the knowledge of the speakers that have been gained along the way. And indeed, when we were discussing this last week, Darren Brown mentioned that it's as much about a physiotherapist's journey as it is about the patient journey. And speaking of Darren, as you know from the program, he was due to speak this evening, and unfortunately he was unable to join us due to another episode of long COVID disability, which I think really brings home to us as physiotherapists the unpredictability of this virus. And we send him warmest physiotherapy wishes for a quick and full recovery. The journey from acute to long COVID, I think, also reflects the development in Europe, and indeed our speakers this evening reflect the situation in Europe. You can forget the harrowing scenes from Lombardy in Italy, where the virus first made its appearance in Europe, and Martina Sant'Ambrogio from Italy will be talking about her experiences, while from the UK, Kola Akinlabi will speak of his experiences in running a long COVID clinic. And again from the Netherlands, where Anna Loes der Valk will speak about adverse reactions that she is seeing, as well as her involvement with WHO, right through to Israel with its high vaccination rate and where life is quickly returning to normal, and from where Hadas Mantin will talk about data as well as what she is seeing in children and in older people. And now I would like to hand you over to Femke Druus to introduce herself and to talk to you. Thank you, Femke.
Yeah, thank you. I will first show my screen. Is it all clear? Can you all see it? Final check. Yeah, all right. Well, good afternoon, everyone. It's my pleasure to present to you today on the recommendations for physiotherapy in patients with COVID-19. My name is Femke Druus. I'm a physiotherapist, health scientist and policy advisor, and I present on behalf of the Royal Dutch Society for Physical Therapy, the KNGF, from the Netherlands. In the upcoming 30 minutes, I will guide you through the following. First, I will start with the global perspective on COVID-19. I will show some data from Europe and the Netherlands, and then I will zoom in on COVID itself, what it does do to the body, and which symptoms people have, and which complaints do they have after their acute infection. I will explain the important role of physiotherapy in the recovery and rehabilitation of patients, and then continue with the recommendations for physiotherapy assessment and treatment. And in that, I will make a distinction between physiotherapy services in the acute hospital setting and after hospital admission, or in patients who went to COVID from home. Well, as you all might know, the outbreak of COVID-19 appeared in Wuhan, China, 2019 December, and thereafter quickly evolved into a worldwide pandemic. And as you can say, it was a global surprise and not a very nice one. And we might say that it turned also into a global burden. Due to the fact that the COVID-19 virus is highly contagious and infectious, many patients around the globe were infected, sick, hospitalized, or even died. And to date, the numbers are still alarming. There are more than 142 million confirmed cases worldwide, and almost 3 million people died because of COVID-19. And as you can see here, numbers have been increasing throughout the 1 year period. The numbers of people being affected with COVID-19 vary around the globe. And currently, the most confirmed cases are seen in the Americas. However, Europe is the next in line, which is in this case not a very good thing. Here you can see the numbers for Europe. We can see that the largest increase in confirmed cases actually started from October. Let's take a quick look at the numbers in the Netherlands, just to give you an impression. Well, in the Netherlands, the first so-called wave of cases started in March 2020, which led to a national lockdown. However, at the moment, we are already in the third, or maybe you can even say fourth wave, which is even bigger than the first one. At the moment, we have around 7,000 new cases per day, and in a country with 70 million people, that's quite a lot. And here you can see the numbers of people admitted to the hospital. As you can see here, in March, the increase was higher and faster. And from September, it was increasing again and is only slightly decreasing since December, but actually not that much. And we are therefore still in a semi-lockdown. To understand the symptoms of COVID and the consequences it causes in people, it is important to quickly tell you something about how the virus works. COVID-19 is a beta coronavirus, and it consists of an RNA strand with a protein shell. These proteins bind to the ACE2 receptors of the cell and allow the RNA to enter the cell. After the RNA entered the cell, it starts to divide. The incubation period is therefore 2 to 14 days, and with an average of 5 to 6 days. So after being infected, it can take a couple of days before people get symptoms. There is also still uncertainty about the duration of contagiousness. Some studies report its contagiousness in a range of 8 to 37 days, which an average of 20 days. But in another study, 50% of patients were still contagious after being symptom-free for 8 days. The most common symptoms are fever, fatigue, cough, and shortness of breath. But patients can also experience weakness, weight loss, headache, nausea, and vomiting. In patients with COVID-19, the severity of illness varies. Roughly, it can be said that 80% of the patients shows mild to moderate symptoms. And these patients can stay and recover from home. Around 50% will develop severe symptoms for what hospital admission is required. Critical illness is seen in 5%, and these patients need to be admitted to the intensive care unit. People at a higher risk for developing severe symptoms are men people older than 70 years and persons with comorbidities such as hypertension, diabetes, or chronic lung disease. However, this does not mean that younger people cannot be infected or become sick. After being infected, patients can experience various complaints and problems in their daily life and physical functioning. In patients who have been admitted to the hospital, and in the ICU in particular, acute respiratory distress syndrome can be seen. That is an acute failure and dysfunctioning in breathing. But also ICU-required weakness, so lots of muscle mass loss, and symptoms of the post-intensive care syndrome are seen. In these patients, both physical, mental, and social problems are seen, for example, depression and anxiety. But not only in people with severe or critical illness, these symptoms can be seen. All patients can show impaired function of body systems such as cardiovascular, respiratory, or neurological system. So after the infection, patients can experience various complaints and problems in their daily life. I want to highlight two studies from the Netherlands and Belgium to underline the persistence of symptoms. In the first study, more than 2,000 patients were reported, were reported persistent complaints, of whom only 5% had been in the hospital. In this study, they assessed 29 symptoms during infection and after a 3-month period. They showed that patients after 3 months reported a total of 14 symptoms, which is actually quite a lot. And 97% reported to have 5 symptoms or more. And fatigue and shortness of breath were the most reported. For example, during the infection, 95% indicated to experience fatigue, but after 3 months, still 87% reported fatigue. And the same was actually seen in shortness of breath. During the infection, 90% reported this, but after 3 months, 71% still indicated to experience shortness of breath. Here you can see an impression of the health status they also assessed. Before the infection, the majority of patients reported to have a good health status, which is the green column at the left. But after 3 months, most people perceive their health as moderate or even poor. And that is indicated by the orange and red columns at the right. And this actually shows the impact of COVID on patients' health, but also their quality of life. In the same cohort, health status, functional status, and quality of life were assessed in a smaller group of patients about 3 and 6 months after onset. In comparison to the symptoms reported during the infection, symptoms decreased from 15 to 6 at 3 and 6 months. But only 5% reported no symptoms at all at 6 months. After these 6 months, self-reported good health, functional status, and quality of life did increase, but a large proportion of patients still experience persistent symptoms. Fatigue and dyspnea were the most reported, but also patients indicated to experience moderate to poor health, moderate to severe functional limitations, and impaired quality of life. Here you can see the reported symptoms during the infection at the left boxes, and at the right after 3 months. During the infection, patients reported 6 to 20 symptoms, such as headache, pain in the lungs or muscles, or dizziness. And after 3 months, patients most frequently reported 1 to 10 symptoms. But here you can see the symptoms at 3 and 6 months, at the right and at the left. In other words, symptoms are still very persistent. To be able to explain the role of physiotherapy, I will briefly show you the various journeys of patients in the Netherlands. Patients with mild to moderate symptoms go through COVID at home and recover from home. Patients with severe and critical illness will be admitted to the hospital, and after that, some patients will be discharged and go home again, but others need more intensive rehabilitation and will be referred for multidisciplinary rehabilitation. But overall, physiotherapy plays an important role in the recovery of these patients, independent of the patient's healthcare setting. However, in March 2020, evidence, knowledge, and clinical expertise regarding treatment of this actually new patient group was lacking. There was an urgent need for guidance among physiotherapists regarding decision-making and treatment. Therefore, we developed clinical recommendations on physiotherapy treatment together with physiotherapists, researchers, and patient representatives. We developed recommendations for physiotherapy in the acute hospital setting and recommendations on physiotherapy in patients after hospital admission or patients who were ill at home, so without hospital admission. And both of these documents will be soon under revision, and today I will present therefore the main recommendations. The recommendations for hospital-based physiotherapy were divided into recommendations for patients admitted to the COVID ward and to the ICU admitted patients. The main focus of physiotherapy on the COVID ward is respiratory support and active mobilization. The same counts for patients at the ICU. However, passive mobilization is sometimes required due to the sedation of patients and mechanical ventilation. Respiratory support is defined as the proactive approach to minimize the respiratory symptoms during the acute phase. Active mobilization concerns the proactive approach to support any physical activity where patients assist with activity using their own strength and control. Critically ill patients are often deeply sedated and mechanically ventilated, sometimes even in prone position. The focus on physiotherapy is then on maintaining joint mobility and preventing soft tissue contractures. When patients are conscious, PT management focuses on respiratory support and active mobilization. In case of prolonged weaning, respiratory muscle training can be discussed in the multidisciplinary team. And active mobilization should aim to prevent ICU-acquired weakness and deconditioning from immobilization and illness. And active mobilization can be stimulated by using bed mobility activities, for example. At the COVID ward, respiratory support serves several purposes: to improve vital capacity, to evacuate secretion, and to strengthen respiratory muscles. And to prevent further deconditioning, active mobilization focuses on improving physical functioning, for example, again, by using the bed mobility activities. And physical activities should be stimulated as much as possible, of course, based on patients' needs, preferences, and their level of physical functioning. The pursuit of PT treatment is often required at hospital discharge. So discharge information can be very helpful for physiotherapists in the clinical practice setting who continued treatment. An important information is shown here. You can find these recommendations in an English paper for which you can use the QR code you can see here. As I said, the recommendations are currently under revision, and a new version will be expected in a few months. Then we will continue to physiotherapy treatment in patients after or without hospital admission. Again, because the evidence was lacking, we used a more pragmatic approach for the development of these recommendations. We formed a working group with researchers, physiotherapists, patient representatives, and guideline experts. And knowledge was shared, and clinical experience from hospitals, rehabilitation centers, and general practice perspectives were discussed. Consensus was reached based on physiotherapists' initial experience with COVID-19, combined with available indirect evidence, mainly derived from cardiorespiratory rehabilitation and rehabilitation of patients admitted to the ICU. These recommendations were thereafter published in an open source KNGF position statement in Dutch and in English. Physiotherapy plays an important role in the rehabilitation of patients who experience limitations in daily physical functioning. Reduced functional capacity and physical activity and limitations in daily living activities can be seen in various patients. Not only patients who were ill can have, who are very ill can have persistent symptoms, but also patients who have at first mild symptoms can experience limitation in their daily life. The same counts for patients with or without comorbidities, and the age of patients can widely vary. An important thing to note here is that in the delivery of care, you as a physiotherapist, your safety is very important. So therefore, always follow your national guidelines on safety, infection control, and transmission prevention. Physiotherapy treatment focuses on improving muscle strength and balance, exercise endurance, breathing, and relaxation. Based on time after illness and experience physical abilities, the clinical recommendations are divided into two main sections. The first 6 weeks after hospital discharge or illness at home, and the period after this 6 weeks. Initial treatment in the first weeks focuses on gradually increasing daily life functioning. And after 6 weeks, treatment can focus on improving activity levels. Of course, treatment is always based on the patient's needs and abilities. Screening for red flags prior to further assessment and treatment is very important. From some red flags, when present, the assessment or treatment must be temporarily stopped. For other red flags, the physiotherapist should consult a doctor, for example. In patients with COVID-19, fast decreases in saturation can be seen, but also fast increases in heart rate. Therefore, attention should be paid. And yellow flags are also important to take into account during the assessment and treatment sessions. Yellow flags are factors that may negatively influence the recovery, such as dysfunctional breathing, fear for exercise, shortness of breath, or negative beliefs. And many patients experience anxiety after hospital discharge. We therefore advise to screen for these factors that may require involvement of other healthcare professionals, such as social work. In the first 6 weeks, firstly determine whether there are limitations in physical functioning, and assess the functional outcomes as you can see here. Also monitor the reactions of patients on activities, such as the shortness of breath and the oxygen saturation. In our position statement, we recommend to use a core set of outcome measures, of which you can see an overview over here. You can find them in more detail in the position statement. In the first weeks, the emphasis is on returning to activities of daily life living. So advise and coach the patient to gradually increase physical functioning. For example, mobilization exercises aimed at daily activities and exercise to improve strength using functional exercises like 10 times standing up from a chair. During treatment, a maximum score of 4 out of 10 on the Bolk scale for shortness of breath and fatigue, short version, is recommended. And in many cases, patients need to be slowed down because they want to do too much. And if so, they might fall back in their recovery and can be exhausted for days. Also monitor the oxygen saturation prior to, during, and immediately after exercise. In case the saturation level is decreasing, it is important that the saturation level reaches its pre-activity level measured at rest within 2 minutes. In our position statement, we included some examples of exercises, including the frequency, intensity, type, and time or duration, also known as the fit factors. Here you can see an example to increase muscle strength. More examples can be found in our position statement. After 6 weeks, always start with an evaluation of physical functioning. Clinical outcome measures should be used again to evaluate current or set new or adjust treatment goals. Again, monitor reactions and body functions. Here you can see the core set of functional outcome measures for after 6 weeks. Again, you can find detailed information in our position statement. I will continue because of the time. The treatment plan depends on the activity levels of the patient prior to the infection, their recovery of physical functioning in the first weeks, their request for guidance, and their current physical abilities. You can coach and support the patient to increase exercise intensity, if that's possible, and focus on patient's personal goals, and focus on both activities as participation, for example, in work situations or returning to sport. Treatment aims at helping the patient to return to social and community participation. In this phase, use a maximum of score of 6 out of 10 on the Bolk scale. And even if needed, keep monitoring the oxygen. Again, the position statement gives a few examples for exercises. Here you can see an example to improve exercise capacity in this phase. To shortly recap, in the first 6 weeks, focus on gradually increasing daily life activities at low intensity. You probably really have to slow the patient down. And after 6 weeks, further improve activity levels and intensity. Monitor and evaluate because every patient is different and therefore unique in its own way. Physiotherapists are also encouraged to work together with other physiotherapists and/or with other healthcare professionals to ensure adequate treatment for COVID-19 patients. The patient's complaints are namely often multidimensional, so interprofessional collaboration is very important. For example, with the GP to monitor or evaluate progress, but also with other professions, such as a dietitian, since patients who have been severely ill, malnutrition is frequently seen. And then combined treatment is very important for the best treatment effect, because you cannot build muscle strength if muscles cannot be built within the body. But also with occupational therapists to focus on how to make optimal use of energy during the day, or speech and language therapists to provide support in chewing, eating, or swallowing. I almost came to the end of my presentation, and I shared probably a lot and in a short period of time, so I will summarize the most important things for you. So many patients perceived complaints after COVID, and also people who have mild symptoms of during the infection can have various symptoms which are also persistent. And these persistent symptoms can really affect daily life. Old and young people can experience severe complaints. And this is also seen in patients who are not admitted to the hospital. And especially physical functions are impaired frequently. So physiotherapy plays a key role in the recovery of patients. Caution with intensity of activity and exercise is needed. And gradually increasing daily life activities is the first focus. After 6 weeks, if everything is going all right, intensity can be improved. But always monitor, measure, and evaluate. Recently, more evidence is emerging on rehabilitation after COVID and persistent symptoms and the so-called long COVID, which will be discussed later tonight. More patients are being under treatment and the experience of physiotherapists is increasing. Therefore, based on new knowledge, we aim to revise the current recommendations in the upcoming months. But also in the Netherlands, multiple multidisciplinary guidelines are also being developed lately. So both the delivery and the organization of care for these patients is something with high priority. As I stated multiple times, all recommendations and more detailed information can be found in the KNGF position statement. You can also access this freely through our website, which you can see here, and you can also use the QR code. In our position statement, you will find more information on the red and yellow flags I shortly discussed, but also on outcome measures, treatment intervention examples, and signs of physical or psychological distress. Now I really almost came to the end of this presentation, but not before I acknowledged the KNGF development group, which you can see here. Thank you very much for your attention. I will shortly show some references if you would like to take a picture or something, and then I give back the word to Esther Mary, I think.
Oh, thank you, Frankie, for a very interesting lecture. We didn't mention it. Participants can put up questions in the box. You can please be sure to write your questions in the questions part and not in the chat. So you can, if anyone has a question, and I would like to ask a question, Femke, but before that, the KNGF has produced so many excellent guidelines, so it's an opportunity to thank you and for the effort to translate it into English. And I think many of us are using them as a reference, so thank you for that.
Yeah, and thank you. Welcome.
There was a debate, there is a debate about a gradual increase of exercises with COVID patients in different stages. Is there some literature on it? Are you coming across some some evidence, or is it just everyone shouts at the top of their lungs?
Well, the evidence is still emerging. So we are lately there are more papers and literature on the rehabilitation, but also the recovery of patients, and that's indeed says that, well, like I said, every patient is different. So in some patients, the gradually increase is very helpful, but for others, they experience a lot of exhaustion, like strong, high, intense exhaustion, let's call it that way. And at the time we developed these recommendations, yeah, that was not known yet. So we are very grateful for all the evidence that is emerging, and that's one reason why we want to revise the recommendations to maybe add something about the group which doesn't respond to the gradual increase or to actually increase intensity, and for the group that has a fallback or extreme exhaustion. So that will be updated, but for now I'm not sure yet, because we have to discuss it and read all the literature.
Thank you. Alex, are there any questions?
Yes, there are. There's 3 questions so far. So the first one is, what do you think about using chest expansion measurement for initial assessment and follow-up as a clinical assessment of physiotherapy input?
What kind of assessment?
Chest expansion.
Oh, the chest expansion. Well, I'm not working clinically with patients, so maybe I can ask Anneloes if she has experience with this, because I'm not sure about this assessment. So I don't want to say something which is not true.
You mean the chest? Can you repeat it for me, please?
Chest expansion.
It's
chest
what
expansion.
do you think about using chest expansion measurement for an initial assessment and follow-up? So I'm assuming
and they mean
using
for the MIP training?
I think it's in
Yes,
terms
okay.
of an outcome.
Yeah, with the long COVID patients, they are tested at the lung at a pulmonary doctor, and if the MIP is under the 70%, we start the training for the inspiratoire muscle strength. So we use it not often, because we only see it with the patients that were on the intensive care unit, or they were at a hospital, they were hospital admitted. For the people that were sick at home, we use it, yeah, not that often.
Thanks.
Thank you.
Next question is, how do you provide post-COVID physiotherapy? Is it online, or do patients come into a rehab center?
Well, as shown in the beginning of my presentation, in the Netherlands, we have multiple settings where physiotherapists can work and also treat patients. So when patients are admitted to the hospital, you have physiotherapists within the hospital who treat them. But after the hospital, or in patients who are not been admitted to the hospital, we have a lot of physiotherapists working in a clinical practice setting, and our advice, due to the contagiousness and the infectiousness, we recommend the first 2 weeks to not have direct contact, so preferably by e-health options. And once you're really sure that a patient is not tested positive anymore or contagious, you can go, you can deliver care through a home visit, for example, if the patient is not able to come to your practice. So you can come him or her to support with treatment options within their home setting. So that's our advice. And you also have patients who are, yeah, let's say too good to stay in the hospital, but too bad to go home. And for them, there is like a in between, which is the rehabilitation centers, and then they're admitted to the rehabilitation centers and treated within the rehabilitation centers by physiotherapists, for example.
Thank you. The final one then is, do you use exercise tests before recommending aerobic program to your patients? How do you define the target heart rate?
Yeah, that is sometimes difficult because sometimes in the hospital at discharge, some people are tested by a pulmonologist or something, or cardiologist. So then you have reference values to use, but yeah, this is not always the case. And at the beginning, some patients are not really, let's call it, suitable for these kind of tests. So then it's really important to monitor and measure the heart rate and the reactions of the body yourself to see what's happening within this patient, what is normal prior to treatment, but also during and after, to get an impression of the body reactions. And if you're really not sure and the patient can handle it, and it is within your healthcare system, of course, you can ask for some kind of test, but preferably, I think, in the hospital, well, at least in the Netherlands, that is the case.
Thank you. Thank you, Femke, and we'll go on with the panel. So thank you all for participants for joining this panel. It's been a truly strange year. We were very much isolated, but then we were all experiencing many things which were very similar. So it has been strange to be so far apart and then in the same boat, both at the same time. And now when it seems like we can see the light at the end of the tunnel, at least for most countries in Europe, starting to see it, we thought it would be beneficial to share some national, local, and personal experiences, to reflect on what we went through apart and together, and maybe look ahead to some lessons and directions. With us to share their experiences and insights are Martina from Italy, Hadas from Israel, Annelus from the Netherlands, and Kola, who's joined us right at the last minute, and we thank you for that, from the UK. Alex will be bringing in your questions. She will be the moderator, and I will chair the session. And we'll start with the first one who met this tsunami, which is Martina in Italy, and you are also from Europe's first epicenter for Milano, right? So how was it? What was it like going through something nobody really understands?
Okay, so I hope everyone can hear me. I had some connection problem before, but now everything seems to go properly. And thank you very much for the opportunity to share our experience here. Actually, I come from Milano. It's in the Lombardy region. It's the first region hit by COVID in Europe. And it was difficult to be the first one. It was difficult because no data and few guidelines were available at the moment. And if we think about the post-acute phase and the post-acute management of COVID patients, actually it was even harder because the first guidelines were on acute settings. So after patient hospitalization, more or less, as for Netherlands, in our country, more or less half of the patient, maybe less than half, were sent to rehabilitation hospitals, and the other half were sent home. And at that moment, the indication for patient at home were isolation until they had 2 negative nasal swabs. So patients at home were isolated and more or less alone. What we have done was sharing experience between clinician and physiotherapists and pulmonologists. So we developed some suggestions and recommendations for patients that were admitted to rehabilitation hospital, and also suggestion for patients that were at home and that were based on the first experiences, the first data, and also based on what we know, what we knew from other respiratory diseases. Actually, I work in a acute hospital, so we had also follow-up, an outpatient follow-up of patients that were discharged from the hospital that we have seen at 3 months after discharge from the hospital, and then later on. And what was quite unexpected and surprising was that actually it was very difficult to define a phenotype of COVID patients. So we have patients with different symptoms, a variety of symptoms. They were quite heterogeneous. So there were patients that have a full recover and patients that still have symptoms, and also patients that have moderate COVID can develop symptoms, long-term symptoms. And surprisingly, also we found that some patients started developing symptoms when they came back to their normal life. So they started back activities and they started to have some problems. So this was quite surprisingly unexpected, and at the beginning it was very difficult to address because we really cannot have a clear picture of what we were expecting in the post-acute phase. Then we also developed some hospitals in my region developed also system of telemedicine for patients that were at home, so to offer some physiotherapy at home. There are few data for now on this type of patient, this type of treatment. This was not done clearly in my hospital. We actually used more telemedicine for patients with other respiratory diseases that were not accessing the hospital during COVID pandemic. So we had both these two problems to address. So trying not to forget the other patients, non-COVID patients, and how to face this tsunami that really hits us in the first. It was quite hard. So this was more or less our experience in the first. I don't know if there are some question or point that you want me to address more, or
Thank you. We can come back to that later.
Yeah, sure.
Yeah, thanks. Good. So our next speaker is Adas from Israel, and you are from the public healthcare organization that publishes all that big data on vaccines. I'm sure you'll have some data for us as well. And you work in different settings. Can you tell us a bit about that?
Yeah, I hope you hear me all okay. My name is Adas. I am a physiotherapist at a Clalit Public Healthcare Organization. Is one of the 4 care organizations that is in Israel. Yeah, we have a lot of data about the vaccination and about the COVID pandemic, but I will present it during on. I work in the hospital of Schneider Children's Medical Center and at the outpatient clinic in the Clalit. In Israel, we have a rule that the patient that released from the hospital can go or to his home and to get their multidisciplinary care at his home. The rehabilitation will be at his home. And after he will get better, he will move on to get the next rehabilitation at the outpatient clinic, or he can release straight from the hospital to the outpatient clinic. We have those 2 roads to go. We do also respiratory physiotherapy for those patients with the long COVID, and we do functional rehabilitation and after the COVID. I would like to, I work also with children and adults. So I have I've seen all of them. I will give you some data that we have. First of all, the Clalit has been vaccinated in 2 doses, over 5 million people. It's a lot in Israel terms. So we had the registration about the COVID patient who were sick and get treatment are not so correctly, because we, at the beginning of the pandemic, nobody knew how to call it. First, some of them called ARDS, pneumonia. They had a lot of diagnostic, but nobody still got the COVID diagnostic. So a lot of data are missing. But if we look on the data that we do have, we had, if you look on the hospitalization, we have 2,500 patients with COVID who got physiotherapy. Those who got physiotherapy after all the patients under COVID diagnosis, they were hospitalized in moderate to severe condition. 15% of those of the 2,500 proceed to the home care unit. They got the treatment first at home. And 25% of the whole patient who got physiotherapy eventually got to the outpatient clinic, which include also those who finished the home care and those who got straight from the hospital to the outpatient clinic. Usually, when we look at the outpatient clinic, 85% of the patients were over 65 years old. And since the COVID pandemic, we saw that only 67% of them were over that age, which means we see a slight lower age of the patient who needs home care. And it's new for us because usually we are used to older people who needs the home care, can get to the outpatient clinic. And now we see more and more younger people who needs first, as you said, the home care rehabilitation because their condition is very severe and they have a low functional ability. Also, as far away from the hospitalization, there are less and less respiratory treatment and more functional treatment, which is something also new because it's at the beginning we all thought it's a respiratory disease, and then we find out that it's less and less. If we look, I want to point out 2 things. First of all, the children. The children are, we all say they are not sick in this pandemic. They can get a COVID, but they mostly will be asymptomatically. And then we can see it's not quite true. So those who were hospitalized, they were moderate to difficult conditioning. And we see that all of the hospitalization and the community who got physiotherapy, yeah, there were less than 7% of the sick people of the sickness in the age of 0 to 18. We don't know how much of them had a long COVID, but actually lately we can see quite an increase of the children that come to a pulmonology with the diagnosis of they have a short of breathness. They feel when they do sports they can't breathe, and when they rest they can't talk over 2 sentences. And we start to see more and more symptoms that's quite logical for us. But when the pulmonology make tests like functional test or a respiratory function test, or try to find what's wrong, we can say, they can't find nothing. Everything is okay. Clinically, when you examine these children, you see that everything is okay. And then when most of them will say it's anxiety, you need to go to a psychologist or to other treatment, but not it's nothing clinically that we can say you need to treat that. And I asked them to keep on for my treatment, to come to me, and I start to see that there are changes in the respiratory patterns and the respiratory chest expansion when I measure them, and I can see there is changes to they start to breathe epically, and their respiratory pattern was changed because of the anxiety and because of all the disease, even if they didn't have any symptoms when they were having COVID. Another side effect of the COVID that we saw in Israel in some slight increase, it's the elder people who had no COVID. There were no sick, and because of all the lockdowns and because of the fear to come out of the home, we're talking about people over 70, and they were so scared to come out. So they until they were vaccinated, and we can see that because of the lockdown, they stopped doing sports, they stopped going to all the participants, they locked down and stayed in front of the TV on the couch and didn't move. And we see functional deterioration and also mental deterioration and all the disease that were quietly in there, like Parkinson or like a stability and everything, increased over this lockdown. And now we have more and more older people coming to our outpatient clinic because of those symptoms, because of those lockdowns. So it was another side effect of the corona that influenced our older people in the country. We have more experience. I would love to answer your questions. Thank you.
Thank you. And we'll move to Analos, who also sees different age groups and has seen some unexpected things of her own. So Analos, please.
Yeah, we also see a lot of difference in the ages. And in the first period, we thought only the older people will get sick, but now in this period, we also see younger people are getting sick. And a week ago, we had in our private practice, I work in private practice in the Netherlands, our 75th patient, we had the intake. And the youngest that we see is 17 years old, and the oldest is 86 years old. The rehabilitation period is average 6 till 12 months. And some are lucky, they have a shorter period. But we also see that we are not used to in the physiotherapy are the adverse events. What it means is that if you overload a patient too much, and my experience is that you do that very quick, you will see that the patient is not recovery as we wish he or she would recover, and that the rest symptoms get a lot of worse. The most patients need then a new rest period, and that's for about 3 days. And after the 3 days of rest, you can start over with the patient. But I see that I have to start most of the time at a lower level. So it's quite often like one step forward and 2 steps back. What we also see often is the long COVID. In the Netherlands, what Femke told is fatigue the most reported symptom. And during the rehabilitation, we test quite often how the functional capacity of the patient is. And we test that on the baseline and 6 weeks after, and then we're 6 weeks after. And at the end of the rehabilitation, we see that the functional capacity tests are fine in the score, but the patient is still telling us that he is so tired. He can still not live the life that he had before the COVID-19 infection. So he says, in the test, I can do everything, but I'm still tired. I still need my rest after doing an activity. So it's not, if you get physical better, you also feel better. So the quality of life for all the patients is still impaired. And now we also see in this flow a lot of younger people that are infected with COVID-19. And the younger people are the students at university or still at high school. And also for them, it is just not a fever. Some of the students say after the infection, I thought I'm young, I don't get that sick, but it's not true. I'm really sick and I still can't do anything. You see that they have problems at recovery in their energy management. They want to do a lot of fun things again, but they don't have the energy. And we also see that they have mental problems. And for example, a mental problem for them is concentration problems. They are not able to study, making the projects, doing the exams. And the consequence of those problems is that they have to quit their study because they don't get the points. In the Netherlands, you have to get points every year. If you don't get them, you have to quit your study or you have to redoing your year. But we don't, we don't have a plan for that students for their problem. So it's important that we don't forget the students because they are the future and they still have to study and do what they like. A few weeks ago, I was invited for a conference call of the World Health Organization, and I talked with healthcare workers from all over the world, And the goal of the meeting was to talk about our experience, but also what did we learn from the pandemic and what can we still learn from each other. It was a really interesting conversation because we never knew Code Black in the Netherlands. So I think we are still lucky in the Netherlands. I hope we will not know what Code Black is. But in Italy and Spain, we heard all the stories about how bad it was. So we learned a lot of each other at that meeting.
Thank you. So, Kola, you are working in a long COVID clinic in London, right?
That's correct.
And can you please just tell us about your experience?
Yes, thank you very much for inviting me to speak at this important meeting. My name is Kola Akilabi. I am a clinical specialist in respiratory physiotherapy, and I work in chronic respiratory disease management, mostly around COPD patient, long-term oxygen therapy, and pulmonary rehabilitation. My background is intensive care respiratory, so I work with quite a lot of arrays of patients with different diagnoses. And most recently, I've been appointed as the clinical lead for long COVID in London, in the UK. And this is on the back of the government of the UK recognizing and learning from what the patients were telling us about their persistent symptoms. So in the UK, in 2020, in October, the government recognized that patients continue to suffer what we call persistent symptoms for 4 weeks and 12 weeks after the initial diagnosis of COVID. And this persistent symptom is actually coined by patients themselves first, and that's where that word long COVID come from. But clinically, we know that is what we call post-COVID syndrome. Now, in the UK, because of that, having recognized that there's so many people continue to suffer from symptoms of long COVID. I mean, in the UK, the population of COVID infection was about 4.4 million people. And as of today, we see how we have about 1 million people complaining of symptoms of long COVID. That's about 1 in 7 in England, and it varies across the United Kingdom nations. I think in Scotland, you probably have, I think 1 in 6 patients complaining of long COVID. The same thing in Wales, about 1 in 5, and in Northern Ireland, you have about 1 in 7 patients complaining of long COVID. And that is why the UK government has set up what we call post-COVID syndrome specialist center across the country. I work in London, and our post-COVID specialist center is University College Hospital in London. And I happen to work within what is called North Central London, and which means that part of my service in London is under this specialist post-COVID center at UCLH. Now, so I happen to lead one of the boroughs of London, which is in Barnet in London, and we have set up a long COVID service. Now, this long COVID service is in line with North Central London with a specific pathway and guideline. With long COVID, within the pathway, patient would have to have a diagnosis of long COVID and before they can come to community therapy services. Now, if I take you back a little bit again, I mean, what we need to do, from what I'm hearing, is a lot of lessons needs to be learned. I mean, we've learned a lot of lessons, I would say, in the UK, having set up post-COVID services across the country, recognizing that a lot of people continue to suffer from symptoms of COVID. Now, I mean, what it's looking like is we need to personalize the care of the patient rather than doing things the way we think patient need them. We need to listen to the patient. We need to listen to what they are telling us rather than what we think should be happening to the patient. I mean, most of the things that I would tell you that we do in long COVID in clinic in London is actually most of it we're learning from the patient, what they are telling us, and we're just taking pragmatic approach in terms of care. I mean, in the UK now, there's something you call personalized care. It's a new national campaign. You would have to listen to what the patient is telling you. This is what I'm suffering from, and this is the service that I need you to provide for me, rather than what you can provide as a service provider. And this is really key and important that we listen to the patient. We need to be able to prepare a little bit better. I mean, we've gone through second wave in the UK. We don't know if the third wave is coming with the way we are opening ourselves up a little bit more. So, I mean, we need to think about our healthcare services. We need to think about funding. We need to think about specialism. Now, with long COVID, from what I've learned, I mean, as you all know, long COVID is a cluster of symptoms. It's not just respiratory, it's not cardiac, it's all sort of arrays of symptoms. It's a systemic disease. It's not a respiratory disease. I mean, most of the patients that have been discharged, it's a publication that came out in the UK, presented in British Medical Journal. Patient that had lung changes, image changes in their lungs after COVID. Some of them recover, some of them don't, but it's only a very tiny number, about less than 1%. So you can see that it's not really a major respiratory disease. And then some patients continue to have microvascular disease. Some of them end up having end-organ disease or like myocarditis. And then a lot of patients, as you know, acutely, they would develop, some of them, at 30%, would develop thromboembolic event. And now there are many studies that have suggested that thromboembolic event can happen throughout the journey of COVID. whether post-acute or even in long COVID, which is why we have to be very careful about risk assessment before patients are actually put therapy and all sorts of exercise treatment. Now, in our center in the UK, we see arrays of symptoms from breathlessness. About 60% of our patients who present with breathlessness, about 89% who present with fatigue. And I mean, a lot of people have questioned that, whether this is post-viral fatigue or this is just deconditioning. Now, we know a lot of patients, we're collecting data in my center that have had ICU care, long stay more than 4 weeks, continue to have post-ICU syndrome, most of them having lower limb muscle weakness, some of them having falls, some of them having brain fog, lack of concentration and processing of words, word finding difficulties. So post-COVID symptoms is well published in guideline in the UK in NICE guideline. Within the NICE guideline, it's very clear the arrays of symptoms from gastroenterology, diarrhea, breathlessness, fatigue, mental health issue, anxiety and depression, lack of concentration, voice issue, speech problem, noisy breathing, all sorts of specialism that you can think about are involved in long COVID. Now, in our center, we have been established in a way that all specialists are present in long COVID care. So I am a respiratory specialist and I work in physiotherapy as well. So, I mean, my remit would be to manage breathlessness with exercise intolerance, with breathing pattern disorder, and targeting their heart rate. Now, I cannot manage gastro problem. I've had patients coming with diarrhea, they come for long COVID. Part of their problem is fatigue and breathlessness. We need to have adequate referral and processes and pathway developed. So we need to develop this. I mean, most of the unexpected is around the fact that we are all surprised at these clusters of symptoms. We're all surprised at these clusters of diseases that people continue to experience. I mean, so we know in our long COVID clinic, patients continue to have about 89%. When we screen them in our clinic, they have breathing pattern disorder, which is one of the things that Hadass Mountain, if I pronounce that right, was explaining as well. And I also echo what Aninos explained about, I think you were trying to explain post exertional malaise. So 89% of your patients that complain of long COVID would have fatigue. Now, we know from evidence, even from chronic fatigue syndrome, that graded exercise therapy is contraindicated in chronic fatigue syndrome, or what we call ME as well. And we are thinking that most of these patients, they continue to experience the similar symptoms of, exertional malaise, tiredness, exhaustion, lying in bed 24 hours after doing exercise or physical activity. So, which is why we have to be very careful with this patient. Now, one of the things that we are also seeing in our long COVID is what we call autonomic dysfunction. Autonomic dysfunction can happen in about 30% of your patient, which is around heart rate variability, orthostatic tachycardia, orthostatic hypotension, I mean. So you have all this stuff. In our long COVID clinic, we do what is called lean blood pressure assessment, lean heart rate variability assessment, lying blood pressure, standing blood pressure, just to be sure that these are our patients, they're not having orthostatic dysfunction before we start any exercise testing. If we are okay that they don't have that, they don't have any chest pain, then we can move on to exercise testing. I mean, I had a patient today. I still had my long COVID clinic today, and one of his main complaints, he's been stable. He was in ICU, and his main problem is dizziness. As soon as we try to do lean blood pressure and heart rate with him, he just started complaining of chest pain. Now he's going to have an ECG, he's going to have an Holter 24-hour ECG. We have a respiratory consultant, a cardiologist we can refer to. We have our post-COVID specialist center that will accept all patients with red flag, and they'll be able to assess them before we can continue to assess patient. If we are happy that patient don't have any risk, what we will do is move them to what we call sit-to-stand testing, 6-minute walk testing, and we use all sort of outcome measure from Namigan, breathing pattern assessment, BPAT we use as well. We use as I said, 6-minute walk test, Borg breathlessness score, dyspnea 12. We use fatigue assessment score, FAST. We use all sort of outcome measure, and we use also PHQ-9, GAT-7 to measure anxiety and depression. So we need to be able to assess all these clusters of symptoms so that one of our specialists can see this patient, or if they have a red flag, they need to go to post-COVID specialist center. If we think that they're not having any one of this problem, but they're having fatigue is a big problem. It underlays every kind of symptoms they may be having. 89% of them will present with that. Some of them will present with breathing pattern disorder. If they have fatigue, they have exercise intolerance, and they have activity issue. What we tend to do is we try to control the fatigue with exercise prescription in terms of managing the exercise and physical activity. So what we are tending to do now is we are measuring maximum heart rate, target heart rate with physical activity providing pedometer for them. So in a way that they don't get fatigue while they are physically active, we prescribe about 50 to 60% of their maximum heart rate of their reserve heart rate as their target. And then in that way, when they get to that level, they can stop and then carry on. So they don't get fatigue, they don't have post-exertional malaise, and their breathlessness is better with breathing control. And then we also teach them breathing pattern retraining. If there's any other end organ disease that we think they might be having, if they have POTS, tachycardia, they would have the cardiologist, or some of my colleagues who prescribe them a beta blocker. Some of them will go on to see even neurologists. So we are seeing arrays of symptoms, and we should actually be learning the lesson. We should be listening to the patient. There are a lot of unknowns at the moment. Most of the treatment that we are offering this patient, they are just trials. We're being pragmatic. We're from our previous experience of respiratory is what we are kind of offering the patient. I mean, what we are offering them in terms of pedometer and target heart rate is what we do in respiratory or in cardiac rehab. So that's what we do in our long COVID in London. I hope I haven't spoken too much.
Thank you. We can see your passion in what you do. Yeah. And Alex, we are closing in to our time limit. Are there any questions?
There are a couple of questions. There were a couple of questions that were left sort of from before, but one of them here, the most recent one, says some of our patients with persistent fatigue noticed that their resting pulse is higher on days on which the fatigue is more severe. Has anyone heard of similar experiences? And how do you monitor training intensity in patients with fatigue? And I think, we do it with, well, it says we do it with the Borg and pulse, which I think has been referenced before. But looking at the nods, everyone's kind of agreeing that.
I think from our facility, I think that heart rate variability is becoming more and more a prominent suspect in a lot of the breathlessness and fatigue issues. So I think the evidence is just starting to come, and we're not there yet, but I think that's where we probably will get some answers.
That's fine. There's another one here that came from earlier when Femke was speaking, but I think it could apply to anyone. Obviously, thank you very much for your continuous effort to move physiotherapy forward. In the acute phase, some evidence is emerging not in favor of working the vital capacity due to the risk of discrimination of the virus to other non-affected parts of the lungs. At what extent do you recommend it? And then talking about most of the severely ill patients will suffer from orthostatic hypotension. So is it worth monitoring that?
So anyone can answer that?
Has anyone heard of that?
That's a very technical question.
Yeah, I think it's worth monitoring the orthostatic hypotension. I mean, because it can cause all sorts of things from, breathlessness to exercise intolerance. So if you measure that first, it's probably a good indicator for you to carry on to do, vital capacity testing, or you want to do exercise testing. So it's really important that, autonomic dysfunction actually is checked in most of the patient. We've made it a point of care that's the first thing we do in all our patients before we carry any other testing.
Okay.
I suppose the other part of it was then saying, is anybody else aware of not increasing vital capacity in the acute phase in case it spreads the virus to non-affected parts of the lungs?
I don't. I haven't heard of such an issue, and with all kind of accessory ventilation being used, I think probably it's not an issue.
May I add?
Yeah.
May I add, please? I think it's not about spreading the virus through the lungs. Actually, it's about trying to take all the sputum out. We never know where is it. We don't know which part is coming on to the lungs. So we cannot actually know about the spreading, but we do know that we have to do the best to take the sputum out and to take all the infection in the lungs and to take care of that. So we do use the breathing in vital capacity, but also we in Israel use the autogenic drainage with huge different volumes of inspiration. So in the inspirium, different volume to get to different area of the lungs, from the small airways to the large airways, and to take the sputum out of there. We know that in the COVID disease, the sputum is very, very, very thick. It's like a hydrogel. So we want to take it out as fast as we can, and we can use different techniques to do that. We don't have to be afraid of the spreading of the virus because it's in the lungs, and the infection will cause more deterioration and more destroying of different parts of the lungs. So we need to take it out as fast as we can, all the sputum. We cannot actually know where it's spread.
Thank you. So I think we should round things up because we are getting to the time limit. And it's clear that COVID has a long-term consequences that we still don't really understand. And we really need to stay alert and attentive and keep providing solutions to patients, but also to healthcare systems and society. And we need to keep that in mind. And one more thing, we just touched it maybe this evening. I think we all lived through a very difficult year with a lot of chaos and uncertainty and quite a few traumas for many physios. So I think we also need to keep in mind that we need to take care of ourselves, and yourselves and your colleagues. And many of us also need to probably heal and recover and get over their experiences. So before I hand it back to Marie, I just want to put it out there that everyone should take care of themselves and and their colleagues and get and recover from this really quite difficult year. So Esther Marie, it's back to you.
Thank you, Neeraj, and I would echo everything that you've said. And I remember last week when we were preparing for this session, and again I'm going to quote Darren Brown, who was unfortunately unable to join us, but he kind of referenced that foursome of the known knowns, the known unknowns, the unknown knowns, and the unknown unknowns. And I think that really covers COVID and what we've heard this evening, in that, you know, we have come a long way. We have learnt enormously, starting with our colleagues in Italy, who really helped us as this virus spread through Europe, in telling us of their experiences. And I'd like to thank everyone who spoke this evening for giving their time, their experience, and their expertise. So to Femke, Marina, Hadas, and Anna-Lush, and Kola, thank you so much. We have been greatly enriched by your listening to your experiences. I think I heard a lot about listening to the patient, and we certainly are good at that, and we can learn from our patients and treat the symptoms that they are telling us about. I'd like to thank the members of the working group, the professional practice working group, again, especially Huss Meerhoff, Nero, Rutam Lehrer, who chaired, and Alex McKenzie, who acted as moderator, and as I say, the professional working group worked very hard to bring this to you. I would also like to thank the Irish Physiotherapy Organisation for the use of its platform, and to my wonderful colleague Fran Theron for hosting it. And as always, thanks to David Correa, the General Secretary, for his time. But this time, special thanks to Aitor Capri, who managed this event from the Secretariat. And thank you to all of you for joining us. We are delighted to have you here in such numbers. And as Neeraj has said, this has been a difficult time for physiotherapists. We've been to the forefront, we've been right across the spectrum, and also it's been a difficult time for member organisations, and I pay tribute to them in how they managed on behalf of us as members of member organisations. So please do take care, do take time out. Hopefully in Europe we are coming through, and I suppose we should remember our colleagues in India at the moment and those terrible scenes that we're witnessing, and just to give a thought to them. But thank you to all of you, and we look forward to more of these webinars, I think, and we look forward to hearing feedback from you if you find it helpful, and I'm sure all of you did. Thank you very much, and good evening.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.
Bye, everyone.
Thank you. Bye.
Thank you. Thank you.